Hello everyone, I am Sulu Fan. Today, let's talk about aortic stenosis, or AS. Among the causes of AS, rheumatic causes is still one of them. However, congenital and degenerative causes are relatively common nowadays. For patients under age of 70, there are about more than 50% have a congenital causes. But for patients over 70, most of them are due to degenerative causes. The normal aortic valve area is about 3 to 4 square centimeters. AS will cause obstruction of the left ventricle outflow, increasing transaortic gradient. If the valve area decreases to 1/3 of the normal area, the cardiac output may be normal at rest, but fails to rise with exertion. At that time, symptoms will occur. AS will cause the left ventricle dilatation and progressing to left ventricular dysfunction. Sometimes the dilatation of the mitral valve annulus will cause the mitral regurgitation. Due to increased left ventricle mass, the left ventricle compliance will diminish. Because the increased oxygen demands caused by the left ventricle hypertrophy and capillary density lowered in left ventricle hypertrophy, and also the subendocardial coronary artery compressed, sometimes the patients will reflect with the myocardial ischemia. The clinical manifestations is the triple symptom complex, that is dyspnea, angina pectoris, and syncope. In about 90% of the cases, the patients complain of the symptoms of dyspnea. That is because the pulmonary congestion. The angina pectoris is due to the mentions what I mentioned just above. And there are 1/3 of cases with the symptoms of syncope or presyncope. That is because during exercise, there is vasodilatation, cardiac ischemia, and low cardiac output, and also vasodepressor response, which can cause hypotension. In addition, some arrhythmias such as atrial fibrillation, atrioventricular block, or ventricular fibrillation with very fast or very slow heart rate can also cause this symptom. The most typical physical examination is the systolic ejection murmur, which is a crescendo-decrescendo character. This murmur is not parallel with the severity. If we hear and adjust by the sound. In the chest X-ray, we may detect normal or slightly enlargement of the left ventricle, left atrium, and sometimes aortic calcification. For those with late stage, there will be pulmonary congestion. In EGG, there are only some non-specific findings. For example, the left ventricle hypertrophy with secondary STT change, the enlargement of the left atrium, and the intraventricular conduction delay, and also some arrhythmias such as atrial fibrillation. Here is the echocardiography of AS. The typical finding is the thickened immobile aortic valve with dilated aortic root, which is due to the post-stenotic dilatation. Usually, the left ventricle is hypertrophic with elevated left ventricle aortic gradient. This is the grading of the severity of AS. We can use the valve area, flow velocity, and also the gradient to grade the mild, moderate, and the severe types. If the valve area is lower than 1 square centimeter, it is a severe AS. Sometimes we need the catheterization to direct measurement if the symptom severity and echo severity don't match, or we can use it before the replacement. Coronary angiography is indicated to screen for patients with coronary artery disease and can be used for patients with both severe AS and CAD before being considered for surgery. Patients with AS may be asymptomatic for many years. When the symptoms appear, the prognosis is usually bad. Complications associated with AS include some arrhythmias, for example, the atrial fibrillation, the atrial ventricular block, or some ventricular arrhythmias. In addition, the cardiogenic sudden death, infective endocarditis, embolism, and heart failure can be seen sometimes. The treatment of AS is as follows. We need an echography surveillance for all the patients with AS. Because AS is a mechanical problem, the medication is limited. Vasodilators are relatively contraindicated, especially in severe AS patients. The definitive treatment is surgery, especially the aortic valve replacement. Also, there are percutaneous aortic balloon valvuloplasty and transcatheter aortic valve replacement. Who need the surgery? Any patients with severe AS and symptoms or decreasing ejection fraction need to perform surgery. If the patient will undergo the CABG of the coronary artery, they can also choose the surgery method. That's all for this section. See you next time.